Morning, this is the House Appropriations Committee. It is Wednesday, February 12th, 2025 at 9 a.m. And we have a full day of budget testimony ahead of us. First up, we have DEVA, the Department of Vermont Health Access, and then we'll have Agency of Legal Services. After lunch, we have Human Resources, the Treasurer's Office, and Corrections. So we are moving all around the state for our conversation today. We are pleased to welcome John Gross, the Commissioner of DEVA, and Stephanie Barrett, our Chief Financial Officer, who were here for budget adjustment, and welcome back. Talk about FY26. Nice to see you again. Nice to see you. So we introduce yourselves for the record and take it away, please.
I'm John Gross, Commissioner of DEVA.
I'm Stephanie Barrett. I'm the CFO of DEVA, and online, I think we might have our deputy commissioners joining us. I don't know if Sandy wants to introduce herself.
Sandy Hoffman, Deputy Commissioner, Department of Vermont Health Access.
Welcome. All right, and there's stuff on our committee page, and also we have copies of not the entire 153 pages. That would be yap phonies. We have the narrative and the ups and downs. We have the condensed version.
I thought you would have read all 153.
Almost. Right.
Just a couple.
You work with no with fiscal office. You just got it though.
Alicia Cooper, our Director of Managed Care, is online as well.
Okay, so point us where you'd like to. I think we're trying to spend some time thinking about your key programs and how successful they've been and what your challenges are and those kinds of things before we get to the ups and downs.
Yeah, so I'll take you to page 23 of the report, just to highlight a couple of our 2024 accomplishments. DEVA remains very committed to value-based payment programs.
I'm sorry, I forgot to introduce Representative Woody Page, who's from the Healthcare Committee as well. So Woody, if you have questions as we go along, just let us know. Great, thank you. Okay, sorry.
No. So as I was saying, DEVA remains very committed to our value-based programs, pay for Medicaid coverage. We currently, and we've been doing this since 2014. The largest value-based payment initiative is the Vermont Medicaid Next Generation Accountable Organization. In addition to this, we are in various stages of planning, designing, and implementing several other programs that you can see on page 23. And we are continuing to increase the amount and the percent of Medicaid dollars that we're seeing following through our value-based payments. In 2024, our reporting cycle reported $1.2 million thrown primarily through alternative or value-based models. This represents about 67% of our Medicaid spend. We're also working on modernizing our business and information technology infrastructure. We're currently undergoing our Medicaid Management Information System program. The goal there is to modernize and integrate and leveraging a configurable interoperable system that can be compliant with CMS. When operational, that will allow us to be more efficient and securely process, manage, and share appropriate data, including beneficiary, provider, clinical claims, et cetera, with other Vermont agencies, providers, and other stakeholders that will meet their business needs.
Is this the one you've been working on for a long time? This is integrated services?
No, that's the next one I want to talk about.
Okay. This is a newer one. How long is this?
So we're currently going through this. They're in several stages. First, we did the Medicaid Data Warehouse and the analytical solution, which is called MDWAS. And that solution is to leverage the technologies through the agency and kind of provide like a more kind of broader data lake, data resource for us. The integrated eligibility, so that's MIMIS. The next one, which you were referring to, is the integrated eligibility and enrollment program, which has gone out for procurement and we're receiving bids for. And that program is really critical to kind of modernize the eligibility and enrollment systems in the state there, and it's working with other departments in ADS as well.
And do you have a date for when a year for when that's supposed to be finished?
So not off the top of my
Okay.
head. In terms of the other thing that we tend to focus on is our operational performance improvement, which is on page 26, and it's really around, excuse me, our quality management and comprehensive risk assessment, really identifying, analyzing, and prioritizing compliance risks across all the departments responsible for Medicaid services to not only DIVA, but other departments as well. We take advantage of any opportunities to move beyond compliance and look for ways to improve the services that we deliver for Vermonters. The other thing under that is really looking at prior authorizations in terms of clinical and pharmacy. The total number of prior authorizations substantially declined in fiscal year 24, where there was a total number of 17,000 PAs, which is a reduction of which is about 43% decrease from the prior year. We've also been able to kind of.
Could you pause on that for a minute?
Yeah.
I know we changed the law about prior authorizations for primary care starting this year, but a decline in prior authorizations for 23 to 24. What does that mean? Are people not getting healthcare? Are they just getting things that don't require prior authorizations? I mean, I don't know how to interpret that data.
Yeah, I will let Sandy Hoffman take over.
Thank you.
We removed the requirements for prior authorization before getting the service. So we looked at data over a 4-year period to determine whether or not prior authorizations was really necessary. We shifted the responsibility to the provider to just keep medical necessity documentation should there be a question, but that we weren't going to determine whether or not it was medically necessary. We trusted them to do so.
And yet there were still 17,000.
Yes. So we do have an imminent harm list, and there are medications because we have the rebate program. So anything that's not on the preferred drug list requires prior authorization. And anything that could be considered harmful to a member requires authorization.
Okay. Good question. Rapush?
So we're talking about prior authorizations from the insurance company. Talking that,
For Medicaid, yeah.
Medicaid,
Okay.
insurance company.
Yeah.
The other question I have is value-based. Could you explain what you mean by value-based? What would be not value-based?
Yeah, I'm gonna this is the great thing about having our deputies here. I'll let Alicia explain in more detail.
Certainly. Good morning. For the record, Alicia Cooper, Director of Managed Care Operations. I have the pleasure of working with several of our teams that focus on provider reimbursement, and our more traditional approach to reimbursement as the Medicaid program has been to pay on a fee-for-service basis, which essentially pays a provider every time they provide a service to one of our members. In that model, there is sort of a financial incentive for providers to do as many services as possible, because the more services that they deliver, the more payments we will make. In transitioning to value-based payment, we have had models that have put incentives in place around quality outcomes and processes for our members. So if providers are perhaps focusing on primary care services and doing fewer services that require more costly interventions like surgeries, there can be financial incentives for them in a value-based payment arrangement to account for the fact that we're not incentivizing them to do more volume in those high-cost settings.
Thank you.
Thank you. Rep. Dickinson?
Yeah, I'm just trying to go through this prior authorization. Now, this appears to be, of course, my computer has decided to go to sleep. It appears to be this is under the pharmacy. Well, clinical and pharmacy, I guess, covers everything. Is that correct?
In terms of our services?
In terms of your prior authorization. Clinical means
Yeah.
primary care,
Acute,
everybody that provides, yeah, okay. Then there's pharmacy. When you talk about, because this is something for Sandy, when she talks about, they looked at let me clarify this. You looked at a 4-year look back and decided there was times when you did not have to get the prior authorization. And now you go and use medical necessity as a criteria. Is that after the service has been provided, or how does that work?
Medical necessity has always been the criteria. We were requiring providers to submit proof that there was medical necessity prior to doing whatever this service was, for whatever services were needing prior authorization. We did a significant dive into, okay, does it make sense? We had the pandemic to use data where we weren't requiring certain things, prior authorization, we suspended the need. So we were able to see whether there was a huge increase, whether there was abuse of the system when there was not a prior authorization requirement. And we found that there wasn't, that in fact, the services that were being performed were medically necessary, and it was unnecessary for us to do a review. So we turned the responsibility over to the providers to determine that. But they're still required to meet the medical necessity criteria and maintain documentation should there be a question. So we monitor data, and if we see a huge increase in a certain service, we can look at it more closely and then review the clinical documentation to ensure that it was medically necessary.
Okay, so let me clarify. So if you have a diagnosis for something, now you don't need to have a prior authorization for the treatment for that or for the drug for that or whatever it is. Now you're going, because of your 4-year look back, you're saying, okay, this is really straightforward. We can approve this, or we can just reimburse this. But you're looking for something that's an anomaly that's coming out of this, a huge increase?
When we do the research and the review of the data, we look for anomalies. But what we did was, so I'll give you an example, like physical therapy. Initially, there was a requirement for prior authorization after 8 visits. It was waived during the pandemic. So we were able to look at the documentation and the ACO, it was waived for the ACO. We were able to look at that the documentation, the data, to show whether or not there was a huge increase for the ACO population when it didn't require a PA, or if there was a huge increase for the non-ACO population when it was suspended. We used that data to inform our decision we modified it to 30 visits. After 30 visits, you required a PA. So it just increased the flexibility around prior authorization. And some we removed totally.
Okay,
Some
thank
prior
you.
authorization requirements we removed totally.
Okay, thank you.
Okay.
And did this save money too? Stephanie?
Business office person, Diva. When a proposals to change prior authorization, eliminate prior authorization, we look at that and do a fiscal analysis if it's going to have an impact. And oftentimes what Sandy has explained too is we look and see, have there been a lot of prior authorizations that have been denied? And if there's not a lot of denials, you know that they're going through. And we find that there's very little or no fiscal impact when those prior authorization change decisions are being made. So that it is a feedback loop on the financial side as well. And as Sandy mentioned, they do the data analysis afterward. And so for something that we have removed a prior authorization for, we'll be going back after a period of time, going back and looking and saying, did that change behavior in the field? Did we have an outcome that we didn't expect because of that? That's the sort of continuous feedback loop around it.
Well, and I would think that it would be, people would get their services that they need, medical services faster, right? And so.
Or less
they get
burden to the
healthier.
physician.
I mean, so it eliminates the annoyance factor for, right, for everybody. And maybe the health outcomes are accomplished more quickly.
Yeah, and one last thing, my experience is that the more times you have to go back and work over a situation, whether it's the paper goes back and forth, or the more times you have to handle it, the more expensive it becomes. So it wouldn't save money to try to do it without that, if you think that if your data shows you that.
Okay. I think we're done with prior authorization.
And then lastly, we've been effectively managing the pharmacy benefit. To talk more about pharmacy, we've effectively managed the pharmacy benefit. Each year, the department reports to the legislature And the pharmacy unit managed about $287 million in total drug spend in the state. That we have seen that as a decrease over 4% over the last fiscal year. The gross spend includes what DVA has paid for pharmacies for all public funded programs, including Medicaid, dual eligibles, the Vermont Pharmaceutical Assistance Program, BPharm. Physician administrative drugs are typically the ones that are processed through the Medicaid benefit, which are not reflected in those figures.
What page?
That is on page 27. The other things I wanted to raise too is that we've completed the post-academic Medicaid renewal start period. We had a 75% enrollment rate, retention rate. We implemented 12-month continuous Medicaid eligibility as well. And we have been able to kind of spearhead the state's response to last year's Change Healthcare cyber attack. Some things I wanted to highlight there. The last thing before I turn it over to Stephanie to go over the budget is that we have 2 required reporting. One on the coverage for dual services for the Vermont Medicaid. That is on page 54 of the budget book, where we worked internally to kind of produce more methodologies. If you want to have a longer conversation there, we can schedule another time. The other one is on page 56, the reimbursement rates for emergency services that came from Act 157 of 2024, which requires the agency to provide the fiscal impact for ambulance services. We calculated the estimate and repriced it at 100% of Medicare's ambulance rates.
And is this, the ambulance, is this treatment without transport or is that somewhere else? That's not you. If you don't know what I'm talking about.
No, yeah, well, you
Okay.
passed the bill last year and there was an amount in there and we went to the non-transport, non-emergency rate.
Right.
And you had a one-time appropriation in that bill and we have
Right.
folded that into our
Okay.
26 estimate.
All right.
That you enacted.
Yes.
And we implemented.
Okay. Great. Thank you. Lynn, did that answer your question? Did you ever?
Yeah, I'm fine.
Okay.
That is all I have on our accomplishments section.
Okay. I'm not seeing any questions, so let's continue.
Okay, so if folks are in the book, the narrative starts on page, have it, that's a different page number. Starts on page 48. And then I'll be using what I call the flow-out sections, but the ups and downs that you're familiar with.
So I think that this part of the narrative we have.
In paper in front of you.
Yeah.
Okay. And so the narrative summarizes the ups and downs lines.
Okay.
But it summarizes, I try and, when one of the summaries touches more than one budget line, I try to note that there.
Okay.
But we'll use the ups and downs as the walkthrough unless, you want to go through the narrative concurrently, or we can switch back and forth.
What do you think people will understand it best?
Okay, well, we'll start with the ups and downs
Okay.
because that's the standard and we'll see where we go. So if you have your ups and downs sheet, we're on section B 306, which is our administrative budget. So DIVA in total is $1.25 billion. A little less than 20% of it is in the administrative budget. That's not an administrative overhead percentage because there are grants and contracts that go through that. But the ups and downs are the incremental changes from 25 as passed, what you enacted in May of last year, starting July 2024. The change from that position to what we see is needed to start the fiscal year this coming July. So these are incremental changes. They're not like a total value for any particular program or function in our admin budget. And some of these are going to be very familiar from from budget adjustment. Beginning in our admin budget, there's the personal services line. And we have, this was the same in budget adjustment. We've had to move the Vermont legal aid funding that was embedded in our programmatic funding up into our administrative funding as a contract. And so that's exactly the same as it was in the budget adjustment. This is now permanently moving it into our base for 26.
Okay, that's the 273,992.
Yes, in general funds, and the same amount in federal funds. And so the total amount for Vermont legal aid is the 547.
Okay, and so that's
34.
your base in your central.
It's always been in our base. It was just down in a different programmatic line, and technically it needs to be up in our administration line. So it's a net neutral move, you know, in terms of the department in gross dollars.
Okay.
And then we have the need to have, I'm in the 25, I'm on the wrong pullout for myself there. Too many pages in our book. Now I'm in the right spot. I was wondering why it didn't start with salary. We're going to talk about legal aid very briefly again. But I'm on page 61. I was in the budget adjustment. I'm sorry, I didn't glance at that. But if you are on page 61 of the budget book, now this should be very familiar. Did you get is that, as long as it says FY26 on the top, you're in the right spot. Thank you. Sorry. I saw some quizzical faces. And I was like,
Yeah, this is the equivalent of page 61.
Right. I got it.
okay.
Put it out, yeah.
Yeah. And it says FY26 B306.
Yep.
And the first line we were talking about, it has a couple code numbers there, 50,000 or 500,000 and then 510 salary and fringe.
Thank you.
That is where I thought I was starting.
Okay.
I was just looking at the wrong sheet. So sorry about that. So these should be familiar from other departments. This is the rollout of the salary and benefit costs on our full staff, which is 372 staff members. So this is the rollout of the Pay Act that was previously passed and enacted. And the rollout, so part of that Pay Act has an impact on our fringe benefits, the ones that are salary driven, percentage of salary. And then it also incorporates the cost increases on for certain benefits, you know, like if the healthcare cost is going up. So that's what's included in salary and wages and in the health insurance, retirement, which is a function of the percentage of our salaries, which is also incorporates, as you well know, the position of the retirement funds in that calculation. And then all the other, it's a very minor amount, but all the other pieces of our fringe package. So that's the first several lines of our administration budget. And I'm going to stop for a moment just to see if there's any questions about those lines. No. Okay. And then last year was the first year we put in for, because the start of the childcare contribution, the workers' compensation insurance, and there's no change to our vacancy turnover, allocation. It's the same as it was budgeted in 25. There's no change to that.
So on the childcare contribution, that's the contribution for all of the employees in DEVA?
For all of the employees.
Remind me how many employees are in DEVA?
372
372, okay.
positions.
Okay. Great, thank you.
And now here is the legal aid change.
Yeah.
So the legal aid change is the same as what we saw in budget adjustment that we just talked about. And then also in our personal service lines are where the DEVA held contracts are budgeted. So the vast majority of our contracts are personal service contracts. And so we have, some of these are going to be very familiar and similar to the budget adjustment as well. The first line item here is we talked about during the budget adjustment. This is a funding switch because of what's called advanced planning documents. It's a way that we fund our IT projects. And we get a better match on those. And this is for certain parts of the program, we found that if we pulled them into a separate IAPD, I stands for implementation, advanced planning document. That's an agreement with CMS to get a higher match rate for certain types of activities, mainly development and implementation, which we get a 90-10 match, at least at the moment on. And then maintenance and operations, APDs, which we get a 25-75 match on. And this change that you see that we saw in budget adjustment is a funding change to identify and put certain activities into an IAPD where we get the 90-10 match, where we're not mixing, because they're purely Medicaid. When we are doing something like integrated eligibility, we can only match for the Medicaid portion of it, and then the portions that are other parts of AHS get a lower match, and you get a blended. And so we went through last year and understood that we could maximize the federal dollars if we, did this work of pulling the right pieces into the structure. And you'll see that again in our operating budget. So we went through an RFP process for our call center last year. And that process has resulted in a newly signed agreement starting for July, and it comes with a higher cost. That's the next line.
Did you have a call center before?
We've had a call center for a long, long time.
Remind me what the call center.
This is in the HAYU in the eligibility and enrollment.
Okay.
The folks, yeah.
And so you have a new vendor?
We ended up choosing the same vendor that we have had for years and years.
They just cost more.
That we've negotiated a new agreement, and it has an increased cost component.
Is that what's the name of the magic or
It is Maximus.
Maximus?
Okay. All right, thank you.
And then we have our some enhanced functionality that we have to include in our Vermont Health Connect. And this is an amendment to a contract that we expect to have that cost come into our budget as a result of that in the early part of state fiscal year 26. That's that 37,000 of general fund, 161,000. So 198,000 total. So when you look at these contractual amounts, the general fund versus the total, you can see the impact of those agreements with CMS in terms of the match rates and the blended function of some of them. And then we have an amendment to our MMIS contract with our that has a cost starting in 26 at 816,000 gross, 129 general fund. And then the one new piece in our staffing budget is 8 new positions in the Vermont Chronic Care Initiative for the Justice Reentry Initiative, which is an initiative we got approval for in our waiver last year. And this is having Medicaid services provided to incarcerated folks. I can't remember if it's 60 or 90 days before.
9 days before, Trevor, is that right?
I'm looking at Tracy.
9 days before.
90 days before. And so this is the case management component of that. BCCI is actually part of the DIVA budget, but it is very aligned with the work out of the central office. And so that's the one new item in our staffing budget.
Okay.
We have our operating expenses. We have, the traditional internal service funds, fee for space, the insurances, the vision, ADS allocated charges, human resources allocated charges. And then we have the same adjustment we made in the budget adjustment to right size our federal spending authority in our operating budget. It was just over appropriated. It's not a change to any program. It is simply correcting an artifact of history in terms of the appropriation level of federal funds in our operating budget.
That's the 8 million.
That's the 8 million. And then you see the same net zero, but funding switches related to APDs. We work very closely with ADS on our IT projects. And so we hold certain contracts. They hold certain contracts and we have an MOU with the work with them. And so we pay for the work and maximize the federal match under that. And that's what you see here. It's the same, making sure that the components of the contractual work that we're doing for our big IT projects, the pieces that are appropriately belong in the Medicaid only APD are placed there. And this is having the funding pieces come out of the right buckets is the result of that. And then the new staff.
Good question here from Rep. Bush.
I'm sorry, going back a little bit, the childcare contribution, can you tell me what that's got?
So the legislature in 2023 enacted a new assessment on employers to pay for the expansion of childcare.
Yes.
And that started in 2024 or 2025, I can't remember.
It started last July, the contribution.
Yeah, and so this is truing up the estimate for the DIVA employees. So this is DIVA as an employer having to pay that contribution. We made an estimate last year of what it would be. And then so it started in 2025, and this is looking at our
Payroll.
yeah, it's a payroll connected, it's a payroll connected assessment. And so when the payroll goes up, it goes up, but also last year was the first year we made the estimate on it. And so this is now trued up to the best estimate of it.
Is the state paying all of it, or are they paying the 0.33 and the employees are paying the 0.11?
Ours is 0.33 as is calculated here.
Yeah, okay.
So we're taxing ourselves.
Payroll. Oh, it's payroll. We're not, it's payroll. It's not.
But we pay
It's an
for it.
assessment based on your payroll.
Right. Exactly.
But we are an employer.
Right, so we're taxing ourselves.
Okay, go ahead.
And then the last thing on our operating budget is the $13,000 you see here are the new positions for the justice reentry. They need equipment, laptops and things to do their work. So, and we don't stockpile equipment. So we need to make sure that we cover that cost.
Good question.
Yes, go ahead, Dave.
On that justice reentry, I'm not aware of the timing of that. Do you know when you might see metrics? The performance metrics?
So-
A year from now, or has it been in place for a while?
So the start of, I'm going to look at Tracy, the start of the program is expected to be January of 26. So this is positions, getting them in place before that starts for the case management. And then in terms of metrics, I would think it would be at least a year after we start where we really start to, obviously, DOC and the central office will be able to say how it's going. But in terms of meaningful metrics, I would think you would have a year out before we would be able to share something truly meaningful in terms of the outcomes of that.
7?
Okay, so now we're going to move into 307. And I'm going to switch to the narrative document for a moment. On page 2 of the narrative document because we usually talk about caseload and utilization all at once, even though it's spread across the 3 budget lines. And you will see them here listed as caseload and utilization. The biggest being in our global commitment line, which is the largest line of our budget. You also see it listed in our state only line and in our non-waiver line. And that caseload and utilization is the result of the consensus process between DIVA and the AHS Central Office, the Joint Fiscal Office, and the Department of Financial Management staff that come together basically through the fall to update our estimates on the caseload and the cost per case for the baseline of what so current caseload, current slate of services, current pricing, no rate changes estimated in that. And we compare that to where we were, and when there's a change in that, and when there was a big change you saw in budget adjustment, and there's a big change in our base budget here, that is the caseload and utilization. That's the base keeping up with where the status is with no changes to the program.
So this is the increase.
This is the increase.
So what does that make your total in this area? If this is just the increase is 51 million gross.
Yes. So the total in our GC line
Yeah.
is 966. So
166 million.
Yeah, so it's about 1.1 billion in total that we spend on services or costs related to our beneficiaries, our enrolled members.
Then this is all Medicaid related.
This is, so in the global commitment, this is all Medicaid that we draw match on.
Right.
We do have we have a program, a line item called state only.
Right.
Out of that, we paid for some things that we don't get match on.
Right.
Or something, and some costs like the clawback that we have to pay back to the federal government as a structure. And then we also have things that are outside the GC waiver, like the CHIP program, and the DISH expenditures are outside. So they're in our non-waiver line. And so that's the reason. It's not to be confusing. It's just that we are, we segment our expenses by what we can draw match on. We segment our Medicaid eligibility groups to some degree by what match rates different Medicaid eligibility groups have different match rates, et cetera. So caseload and utilization across everything in 307, it's $46.1 million up. In state only, it's $1.4 million up, and in non-waiver, it is $3.5 million up, and it should be the first line of every single one of these, but it's not. Sometimes it's the second line.
I don't know if this is the right place, but somewhere in your presentation, I would like to hear from you how you're thinking about planning if more chaos ensues out of our federal government, because you are affected pretty much more than anybody else in the state. And so I don't know if you're having conversations about how to think about it. I mean, there's only so much planning you can do because there are so many what if scenarios. What if they do this? What if they do that? But are you thinking about it, and how are you going about thinking about it?
Do you want?
Yeah, sure.
Yeah, so we are thinking about it. There's a number of proposals that we've seen from Congress, and that we're working internally within the agency to kind of figure out what that financial impact would look like, what would have actually happened to the Medicaid program if these proposals happen. So those conversations are currently going on, but they're just all hypothetical, and we have not seen, but we are aware, and we're monitoring what's going on and working with different sorts of associations and academics to kind of figure out, to kind of keep our ear attuned to like what is going on, what is actually going to may muster its way up.
Yeah, this interests me because I got the mixing bowl.
Okay.
Okay. So you have the gross.
Yeah.
That's under Medicaid, under the GCF. And then you also have for state only and non-waiver. You don't have those in here.
The GF portion?
Well, you have the GCF portion. You
Yeah.
don't have the state or the non, I mean, there would be a state.
So on the narrative,
something
the
million.
GF to the right is the state match. So on this document,
Yes.
so our appropriation is only for the gross amount, the GCF amount anywhere it's GC. So the GF share of that 46 million is the 18.
And you don't have that under general fund. is
No,
that
because
right?
that is up in your mixing bowl in the central
And
office.
that's where okay, and the same with the state only, that would be under.
So
general
the state
fund.
only, no, the state only should be in its various components right there. It's the second line down in line 309. You'll see it down here.
And the non.
Down here,
Okay,
you'll see the exact same, the 1411.
Okay, yes, all right.
Yeah,
I'm just
so
trying to
that's
figure
it.
out where it is, yes.
Yep.
And now what about the 1.012.
So that is over here in the next section, which is 310.
310. Okay,
And so,
okay. Well, I don't have to do it either, but I do have to understand where they come from.
yeah,
Okay, good.
but that 46 million is up in the central office. They have to have the match for that, and because their spending authority is the state and federal funding, and ours is the mixed funding.
Larish has a question also.
You know, back on the federal money, question. You must have some sense of the worst case scenario.
I don't know if we can kind of predict what the worst case scenario is. I
They
mean,
cancel Medicaid, it's the worst case scenario,
worst case scenario, Medicaid completely goes away.
and we don't have a way to backfill that. But that,
But I mean,
then we're gonna have other problems.
exactly.
But there is, as Sean mentioned, we are, paying attention to the associations, like there's a National Medicaid Directors Association. I pay attention to the fiscal side of that, the financial side of that. And some states are doing some modeling, but it's a little bit early.
Right.
And you all, as your connections to NCSL, will be getting the similar type of,
Right.
as proposals become solidified.
Yeah.
And then, understanding what the nuances might mean and what the timing might mean. It's a little bit early to jump into modeling something when the terms aren't defined and but it is important to know what potentially might be on the horizon in terms of changes that, how quickly will they hit us? What sort of, yeah.
So I think it's important that, you don't need to have modeling and solutions for every possible scenario, but the fact that you're thinking about it, whatever happens, and this, I can say this not just for you, but other areas of state government, we're going to have to be reactive because we don't know what it is, right? But the more we know and the more we've thought about it, the nimbler we can be in a reactive response to whatever's happening. So I just want to be sure people are really thinking about it.
We are.
All right, thank you.
As we go through the ups and downs, and I'm going to sort of cross-reference to the narrative document as we do this. But in section 307, after the caseload and utilization, it's the opposite side of the Vermont legal aid transaction. You see the hospice rate increase. That's the same. It's just annualized. It's the same level that you saw in the BAA. We have to keep a floor. We have to keep a minimum rate for a hospice. And then we also have to annualize that indexing that we do on the FQHCs. So it was a little bit less than half a year that you saw in the BAA. This is the same January 2025 index. It's just annualized for 26.
So is that an increase for them?
It is an increase for them.
The FQHCs. Okay.
Yes, that percentage increase, which I believe is 3.5%, it took effect in February, and we're carrying the impact of that fiscally in this budget. We also have, and it's item number 6 on the narrative, we are carrying an increase in our budget for high-cost drugs that are not in our base at the moment. And as you read in the narrative in point 6, that's $4.5 million. There's a lot of activity and new therapies in the pharmacy space. Some of them are very expensive individually. It's not like we're going to have a lot of Medicaid members. We might have 1 or 2 in some instances, but they could have a $2 to $3 million cost per case. So
It would be.
And then some of them are just very high cost drugs of tens of thousands of dollars a year. So for example, we do not cover, it's not a covered service for the GLP-1s for weight loss, but Medicare is covering it for certain cardiac conditions. We have built in an estimate of what that cost might be to our budget in this $4.5 million request. What's not in that is the newest Medicare expansion to the sleep apnea. That wasn't on the scene when we put this budget together. But there are gene therapies. Those are the ones that can be very, very expensive. We know that there's a hemophiliac treatment. We have identified that we could have one or two that are eligible for that. The rebates on those are not as significant, or maybe separate agreements. And so this is our best estimate of a pressure on our budget from these very high cost areas on the pharmacy space.
Yeah, on the high cost drugs, diabetes is being used as a diagnosis to use some of these high cost weight loss drugs, obesity. But diabetes is what I understand to be a primary source of the diagnosis for this. Is that?
So we do, when a person has a diabetes diagnosis, and Sandy can jump in, we do cover that. That's a covered service for the GLP-1s. But if somebody is, if the prescription just for obesity and weight loss, that is not covered. So that's what's not covered. But if they are having the cardiac conditions that Medicare has expanded to, we now cover that. So they can be prescribed the GLP-1 treatment as part of that cardiac diagnosis.
My understanding is that there was an off-label thing for the actual weight loss. I mean, obesity goes with diabetes.
But you have to have the diabetes.
Yeah, you have to have the test that shows that you actually are
Yeah,
diabetic.
For us to cover it as a
Yeah.
Medicaid coverage, but we do not cover it because, for weight loss.
Yeah.
And
The off-label use.
Thank you.
Oh, I have Rep. Saska and then Rep. LaRouche.
So I'm assuming a lot of the cancer-related drugs are in the same class as well.
If they are, so we are looking at the ones that are new that we're not covering now, like what's coming at us that's brand new to us, that's not in our baseline. So I'm not an expert on the pharmacy world. And so we worked with the pharmacy unit to come up with this estimate of what's, understanding what's new on the horizon versus what we do cover right now. And so a new high cost cancer drug that is covered and would come into this. It's not, I don't believe that there were any new cancer drugs in this estimate when we made it back in, the late fall. I know there was a liver disease, a hemophiliac, there was lots of things that I cannot pronounce.
Thank you.
Sure.
And Rep. LaRouche.
So if someone had genetic testing done and found that they had the genes propensity for
The hemophilia.
what we're talking about, diabetes, then they'd be eligible.
I'm not a clinician, so I can't answer that. I mean, if they were a Medicaid patient and they had a diabetes diagnosis and the doctor was recommending a GLP-1 as Ozempic as a treatment, we would cover Ozempic.
Because my thought was, early treatment might save a lot of money for everybody.
Yeah, there's a lot of discussion and there's a report. And maybe Sandy would like to just jump in and direct people to the report that we've done.
We can send it. We can send a link to it.
Okay. Okay. We have a small adjustment in our in our budget, and that's the AXME. This is the direct care. They have a collective bargaining agreement. The majority of this you would have seen in Dale's budget, but we do pay for a certain amount of direct care for basically children. And so that is that $139,639. So that, because that is based on a collective bargaining unit,
Nothing worried about with the collective bargaining, you just kind of.
that's a rate we have to pay. We don't have any choice to pay that one. And then the next line on here is the PRTF. The funding for that began in 2025, and we're very close to starting that program. This annualizes the cost of the program, and that is referenced on item number 7 in the narrative. So this is our best estimate on what those beds will cost fully annualized, and we would expect them to be, utilized in 26 fully. There might be a little bit of an estimate in terms of 25 on the timing of when those beds turn on and how many people are in at the beginning, but this is the inpatient residential psychiatric treatment treat for basically adolescents and up to 21 years old. And then going back to item on our program budget, on the second page, item number 4, the MSP expansion and buy-in. So you enacted in the budget last year an expansion of our Medicare savings programs, which are the buying for lower income folks that are outside the dual eligibility category of Medicare, buying them into the Medicare program so that they get better pharmacy coverage for the most part. So this, you brought the qualified, we call them QIMBYs, the qualified Medicare beneficiaries up to 195%, and the for the QIMBYs, you brought them from 100% to 145%. I'm sorry. And then for the qualified individuals, you brought them from 135% to 195%. That change gets enacted January 2026. And that had a cost. And the cost, when you enacted this, you didn't have to add money in the 25 budget because it wasn't enacted in 25. But we have to cover the cost of that enactment starting halfway through state fiscal year 26.
This was the cliff, right?
It was referred to the cliff.
Right.
Yeah, and so
we have Rep. Kuzenska and then Rep. Yakubov.
So this is new here for me, so I catch up.
Sure.
Here. Can you explain that paragraph again when you're making reference to something going from 135 to 195%? What does that mean? Explain that.
Oh, I'm sorry. That's the federal poverty level. So the individuals that qualify for this benefit, what their income level is at, is what determines which program they are in. And so the limit and the state can control what they are, setting for the limit for these programs. And so those were for the QIMBYs, the qualified Medicare beneficiaries. And there used to be an in-between group that this move also eliminated. So there's only the two groups in our new structure for January. And so for the group that is from 100% to 145, what the qualified Medicare beneficiaries get is we buy in their cost of Medicare and we pick up the co-pays of Medicare for individuals in that income category. And there is a report that I'm sure you've all read on your legislative website on B-Farm, and it explains a lot of it's got a lot of tables in it, and explains the various pieces of the MSP programs and the B-Farm program in particular, because we have an existing program called B-Farm that dovetails or, is aligned to some degree with the MSP programs and the pharmacy programs. And so that is all laid out in that report. For, if you want to go deep into understanding the different populations, the different programs, the different poverty level cutoffs at different, what we do now versus what we're going to be doing in January. That's all in that report. And I will say that you'd asked for a recommendation back in that report. We don't think we have enough information to make a clear recommendation about the future of bee farm in that report. You'll see that in that report when you read through it, that we think we will be ready to make a recommendation next year at this time, because we'll have the program started up, the change that you're making here, because we have a lot of change in the pharmacy space at the federal level that's happening. I don't know if that's helpful to you, but we could go into that now, or we could go into it offline if you want to do that.
And then Rebecca Boney had it.
This program has a lot of potential to significantly help lower to moderate income seniors. Do you know what analysis was used to predict what your volume would be? The reason I ask is there's a small unit, I think they have 4 FTEs that Dale funds with the area agencies on aging, called the SHIP unit, HIP. They're specialists in health insurance programs. But if they don't have any additional staff and we've increased the universe by which people are now eligible, I wonder if we're going to be able to sufficiently recruit more seniors to utilize the program. And if we didn't, how would you estimate the volume increase here? Is that in the report?
So the fiscal estimate that you have in front of you in item 4, that was done internally by DEVA, with the policy person and the folks in the business office in DEVA to look at and analyze the population that could come on under this. And the assumption is we will have very high take up because of the nature of the outreach that happens to this population.
What is that outreach, do you know?
So that is the SHIP folks are part of that. They were part of the stakeholder you'll see in the report that's on
Okay.
Bee Farm.
Yep.
Specific to their capacity, I can't speak to.
Okay, I'll do some research on that myself. Yeah. We'll know next year, BAA time, how close we were.
And
even
what
then they
the
may not, right.
as this change is set to turn on a year from now, January 2026, the activity that precedes that in anticipation of it through the fall.
Will drive the numbers.
Yeah.
So we may not know.
Yeah.
Thank you.
But this change that you enacted has a significant cost. It also, this is only a partial year cost. It will have to be
Right.
fully annualized when you build the budget for 27 next year, just as a reminder. That $10 million cost, though, as you look at this, you can see that in the non-waiver section, there's a good chunk of this, the qualified individuals that are 100% federally funded, which is part of the benefit of trying to, cover as many low, moderate income folks as we can under this. And so, that, notwithstanding federal changes, potentially that is one of the things, the $1.822 million of GF is the net impact for the up that we see on the Quimby population, but that also has a savings we've estimated in the Bee Farm program. So we net the two together to say what is the net cost of the program change. We will, in the business office of DEVA, look at this again as we're building the 27 budget, just to see, as a course of practice, understand where our estimates that we made last spring when you were contemplating this, how do they look now, a year and a half later on the same baseline of data, or anything else that's new to us.
Thank you.
So that change, which is number 4, is you see it in line in section 301. You also see it in section 309, not 301, 307, and then also in 310 as a line item. The next item, going back up into section 307, and we're at the second to last item on this line, is the graduate medical education program. And this one is an up of $7.25 million. That is driven by the estimate of what we can, there's a formula, it's a multi-part formula of what we can expend on graduate medical education under the federal government based on, and that we have one institution, UVM Medical Center, that benefits, it is a graduate medical education location, a facility. We do not have a state general fund match on that. The state match for that is provided by the university. So this represents the increase under that formula for the spending authority we need. But this is the one item in our budget that we need the spending authority under the global commitment, but there's not a general fund component. There is a state match requirement, but it's not provided by the general fund. It's provided by the university.
Okay, let's continue.
The last item in section 307, which it looks like a negative of $4.396 million. If you drop down to the last item in section 309, you see an up of nearly the same, actually a little bit more than that. This is purely rebucketing. We just had the 2 programs, the spoke program, the Blueprint Spoke program, and what's called the Pregnancy Intention Initiative, which used to be the Women's Health Services program. We had them in the wrong category. We had them as programmatic global commitment, and they need to be down in the state only because they're still global commitment funded, but they're initiative funded. So that's why you're seeing the move.
Putting them in the right bucket.
Putting them in the right bucket. And going through on section 8.
Just quickly, can you tell me what page in your binder that initiative is covered on, if at all?
Which initiative?
Pregnancy initiative you were just speaking to?
I will.
If I wanted to learn more about
Yeah,
it. where would I go?
I don't know if we have a section in the binder on it, but it's a program that is longstanding, and the name of it changed a year or 2 ago. And so we'll get you the history of it.
Thank you. Thank you.
And now switching down into section 309, 2 items that we didn't cover yet in section 309. The cost sharing reduction, that is a purely general funded state benefit to reduce these are for the folks that are buying insurance on the exchange. They're not in Medicaid. Up to 300%. We have a premium assistance program that's not changing, but because of the pricing of the silver plans and the gold mapping, silver loading, the cost of the cost sharing reduction plan is going down because we have less people in the silver plans, and it's tied to the silver plans. And so you saw a $750,000 general fund reduction in the BAA.
Yeah.
And that's for the plan year that started January 25. This annualizes that. So
it's a reduction in the subsidies.
for the cost sharing, because because more people are in the gold plans at a better,
That was a better deal this year.
under the tax credits that we get, which is an open question.
That's one of the big questions, isn't it?
For 2026.
Yes. Yes.
At the federal level.
We're talking what, 60 million?
That's the estimate of the total benefit of the tax credits to the state of Vermont. So the folks that are buying,
Yeah.
the folks that are buying insurance on the exchange. And that's folks that we, up to 300%, and folks that, are over that limit, buying plans on the exchange. We talked about the caseload and utilization, the 1.4 in the state only. That is mostly driven by the IHIP program, the Immigrant Health Insurance Program, which is purely GF. We have a clawback increase embedded in our budget for 26. The clawback goes back almost 20 years to the part when the federal government implemented Part D coverage under Medicare. As part of the financing of that, they recognized that states that were providing a pharmacy benefit under Medicaid would have a reduced cost. And so they clawed that savings back from the state. And there's a formula every year on, where those cost projections are and what each state owes back to the federal government. And so we carry that in our state only line. I've heard it referred to as a reverse block grant from the state to the federal government, but it is part of the structure and we have to fund it. And so when we get from FFIS, just like joint fiscal gets an estimates on what those impacts are going to be, like the calculations from CMS, we build those into the budget. Last year, it was a pretty chunky amount. This year, the projection's a lower percentage increase. But it's $1.4 million of GF.
We have other areas of the budget that are unrelated to health that we have clawbacks in. So this is, it's what we.
We talked about the MSP expansion. This is the portion, the down portion of it. So this is the impact of savings on the V-Farm program, because the V-Farm program is mostly funded in this line item. And then we also have the opposite of the transaction for the Blueprint Spoke and the Pregnancy Intention Initiative. And then our last section is section 310. Trouble with the lighting in here somehow.
This used to be a coat room.
My eyes. Can you see the lights?
Walk home with.
It's caseload and utilization. We talked about caseload and utilization in the non-waiver section is entirely the CHIP program. So that's the Children's Health Insurance Program, which, actually stems back almost 30 years to the Clinton administration, and it's slightly higher income level children that we cover. To any member, it's seamless. It's Dr. Dinosaur. There's, a member might not know that they're CHIP versus Medicaid, but we have to. It's a different match rate. It's a different program. We have to carry it in a separate bucket. We have what we talked about in the MSP. This is the qualified individuals up to the 195%. That's the federal share of that. That's you see it carried only under the federal line. And then there's a tiny amount of the Blueprint Spoke that is moving out of the CHIP related Blueprint Spoke is moving out of the non-waiver section and back into what was 309 altogether as an investment. Right. And that brings you to our bottom line on that total down in the blue at the very bottom of the $1.2597 billion.
And this is the base.
This is the base.
One time.
So we do have a one time, and we need to go to that on the narrative. That would be on the last page of the narrative.
We knew this was coming.
So on the very last page of the narrative is a $10.8 million global commitment appropriation to DEVA. That has a $4.4 million match, but that is being appropriated to the central office. But we're showing it here just so you understand what the state match is. And this is a one-time bridge funding because the ACO and the cohort 2 of the AHEAD model is not until 2027. This is bridge funding for the 2026 year for what was provided from Medicare through the ACO to the SASH program and to the Blueprint program. So This is
You're funding it and the
the
during.
proposal is to fund that for 2026, and that's what this one-time represents.
Clarification?
Sure. Go ahead.
Did you say, you mentioned SASH?
Yes.
Could you repeat that line again?
So
Help me.
under the ACO construct that we have in place, have had in place for several years, and maybe Alicia Cooper is the best to explain this. We have had a payment that the ACO as an entity has had monies that have flowed in from Medicare, not Medicaid, Medicare, that have gone out to the SASH programs and that have supplemented the blueprint. And
You're
so.
trying to make that up?
So this proposal is to cover that for the 2026 calendar year. The ACO won't be in operation, and the decision to go with cohort 2 under the HEAD model wouldn't be until 2027. And so this is a bridge for the 2026 year for these components of funding that these entities, SASH and the Blueprint receiving entities, have had under the ACO.
And if I may, and you may have covered this already, but is there similar payment somewhere being made for primary care that used to receive investments, maybe the wrong word, funding from the ACO in your budget?
So the baseline of our budget includes those.
Okay.
So the primary care PMPMs that have gone out through the ACO are in our budget. And so they haven't gone anywhere. They're in the baseline of the DIVA budget.
Okay, you're continuing on.
So, and I'm sorry?
It's not enough.
It's not enough and it's not being redirected somewhere else. We just have to work on, it is there. And we just have to work on the logistics of how it will be.
Delivered.
Yes.
Thank you.
Yeah.
Any questions for DIVA folks? Yes, go ahead,
If I
David.
may, would you as you think about all this, would you characterize your biggest variables to be caseload and utilization, including MSP, I guess?
So,
Mhm.
so I would, caseload we do a pretty good job of caseload. Obviously, the pandemic and the unwind was a challenge. It's just difficult when you're having that change and understanding what it projects. But I feel our consensus group does a very good job on projecting caseload, unless we have a sudden change in the economy and the caseload changes in a way that we didn't anticipate. Utilization and how we understand cost per case, that's more dynamic. So the up you saw in budget adjustment, the up you see here in caseload and utilization, that is all driven by, the dynamic of how services are delivered. And some of it is that we missed the mark in terms of trying to understand what the change in our caseload meant to the underlying stayers and the cost per case. But it's the one, month to month we keep a really close eye on, because we don't control it. It's how services are delivered. And so we're always trying to do our best in terms of setting that consensus budget at what we think we are going to land at. But it's a big budget. So small percentage changes, 1 or 2% change off on our vision of the claims world is significant. And there's always this balance of, do we ask for that? You don't want to crowd out other things in the budget, but you want to get the right level of appropriation and spending authority that's needed for the program.
I was just imagining giving a floor report, just trying to summarize, but and I guess sometimes you can't that much, but.
We'll give you a couple extra minutes, Dave, in yours.
You don't have to, no. You're to someone else, but our total increase, we're moving up to 1.2 billion. And our FY 25 was 1.1.
So no, our FY 25, our program budget, our programmatic budget is 1.1. The 1.25 includes the $182 million of admin.
Every day.
Yeah. And so in total, you can see the total up is across the bottom there. From 1.18 to 1.259, admin and program together.
What percent is that?
Oh, wow.
Well, you don't have to do it right now. It's okay.
I don't know off the top of my head, but it's a 20, it's $70 million on the 1.18. It's a little bit, that $8 million down, that's just a correction, is going to skewer the percentage. The percentage is actually higher if you take that $8 million piece out.
It's about 6.7% with the 8 million
And that is
increase.
mostly driven by our caseload and utilization adjustment that you see there.
Thank you.
Rep. Dickinson?
Yeah, thank you. Do you see any trends in this kind of, these numbers with the aging of the population and sort of building on what David was talking about, you know, as your aging population, when they are sick and they get lower income as they get older in many cases. So, you know, the intensity, it's not just the number of people, it's also the intensity goes up. Are you seeing that anywhere or?
So we haven't, I'll just be honest, we started tracking every meg by age every month in our business office. We haven't been able to dig in deeply yet. But, you know, in terms of trend, the dual population stays pretty steady. In fact, you know, in this book, you have a lot of information. We flip to the dual page. We don't see that as a constant pressure up. 15 years ago, I wouldn't have expected to see that given our aging population.
Yeah.
What that tells me is even though our population is aging, the lower income part of our population is not growing at the same, this is just enrollment in the program. And then intensity of the program across all the different Medicaid eligibility groups. The place where we were most off, and it makes sense under the pandemic, was the new adult population. So the duals were not too far off the mark on, but because that's the most dynamic, people in and out of the program based on, you know, their circumstance and their redetermination, that's where we missed, you know, that our underlying population is still the same. But those new adults are a wide range of ages. They're from 19 years old to 64 years old. And so in some cases, it's sort of a barbell. You have very young and very, you know, people just before they're eligible. But it's a distribution in there. And in terms of, you know, deep dives, I don't know if the data team, we've tried to work with the data team. There's been some, you know, just timing and resource to look at that. But
are you going by the financials? Are you going by what is actually being charged out?
We're going by what we pay.
Or based on what you pay?
Yeah.
Okay. So they might be going up because it's going up by what hospitals or doctors or whatever charge.
So they're
because you're not paying what a lot of times what they charge, what the costs are.
Yeah. We don't generally analyze along what their charges are. We are looking at what our program parameters are and what we pay out.
Yeah.
And the other dynamic in that is that a large chunk of our budget has gone out as prospective payments under the ACO and not as fee for service.
Right.
Still, you know, so there's all those
Yeah,
components
claims.
at the same time.
Yeah.
So there are shadow claims that come with that, and we look at that. That's part of how we look at that. But you know, what that means in terms of how service is delivered is, understanding that is
how that, you don't have those trends that you can look at that are
that
reliable.
Yeah, what we see there, and I don't know if Alicia wants to jump in any way. It's
Yeah, just one last thing. Under the ACO, you were getting capitation payments out of those, and then you would get the files.
I don't think that's quite the right description of the ACO. It's an agreement that we went into every year based on a projected actuarial set rate structure for an attributed population. And then it is reconciled. It takes months to reconcile it. what, to that total cost of care based on what actually
Happened.
happened.
Yeah.
Um,
And that's where you have the shadow.
That's the-
filings of the insurance, of
yeah,
the
we-
applications from us.
so they're still filing a claim, we just don't pay on that claim. We,
Yeah,
and
but you file.
And then
away,
there's,
it's there.
within the ACO, there's the activity, of what they, we pay the ACO and they pay their member providers. And so that's another, that
Piece.
difference, yeah.
Thank you.
Hey, I'm not seeing any other questions. Thank you very much for coming in. We appreciate it. Dave, as you've probably figured out, is your liaison, what we're doing as part of the budget. And so he will be in touch. And I'm just checking our agenda. So we are gonna have a little break, committee, and at 11 o'clock, Agency of Public Services. Oh, fun for you. So-